welcome everyone to the BHF Data Science Centre's monthly webinar. And many thanks to all of you for making the time to attend today. My name is Reuven Pruden. I'm one of the Centre's research project managers with a focus on managing the CVD COVID UK COVID Impact Research Programme within our structured data thematic area, and I'll be chairing today's webinar. Today we're delighted to welcome Professor Kate London and Dr Chris Tomlinson, also from UCL. Kate and Chris will speak about the findings from their recent paper published in the BMJ on the 5th of July, entitled Hospital Admissions Linked to SARS-CoV-2 Infection in Children and Adolescents, a cohort study of 3.2 million first ascertained infections in England. Before I hand over to Kate and Chris, may I please ask everyone to kindly keep their camera and microphone switched off, and to make you aware that this webinar is being recorded and it will be made available along with recordings from our previous webinars on the BHF Data Science Centre's playlist on the HDR UK YouTube channel. There'll be time at the end of today's talk for discussion, so please post your questions in the chat and we'll do our best to answer as many of the questions as time allows. Finally, if you would like to present at a future webinar, do let us know in the chat, and Kate McAllister, our communications manager, will follow up with you. So without any further ado, I'll now hand over to Kate and Chris.
Thanks very much, Reuven, and welcome everybody. Thanks for joining. I am Professor Kate Brown. I'm a children's intensive care doctor working in the cardiac teams at Great Ormond Street Hospital, and I'm also a professor at Institute of Cardiovascular Science. And I'm going to introduce my co-speaker. Chris, would you like to unmute your mic and introduce yourself?
Yep, sure. Hi everyone. I think I know a lot of you, but I'm Chris Tomlinson, a PhD student at the UCL Institute of Health Informatics with a background in adult intensive care.
Thanks so much, Chris. So we're going to present the webinar today, as Reuven has said, about our study, which is hospital admissions linked to SARS-CoV-2 infection in children and adolescents. And this is a cohort study involving 3.2 million first ascertained infections that occurred in England. Chris, thank you. So the background to the study, severe disease, as I'm sure many of you will be well aware, has always been reported as rare with SARS-CoV-2 in children. Research of SARS-CoV-2 infection in children and adolescents and related health policies, notably vaccination, have focused quite strongly on the well-known increased risk with underlying health conditions. The presenting features of SARS-CoV-2 in children and adolescents reported from all over the world, often in small case series, at least certainly early on in the pandemic, were quite variable. And it was noted that the spectrum of presentations had some differences to the presentations in adults. The most well-known and famous difference was the account of a brand new disease, which was reported in the Lancet by Rip Hagen et al. In May 2020. And this condition, which appears to only affect children and adolescents, in Britain is known as pediatric inflammatory multisystem syndrome, temporarily associated with SARS-CoV-2, or PIMS, PIMS-TS for short, and is also known as MIS-C in North America. At the same time, in England, COVID vaccination has been sparse, and indeed it's been less well taken up than in adults in many parts of the world. And we noted that in the autumn of 2021 and spring of 2022, children and adolescents experience some of the highest rates of SARS-CoV-2 infection of all age groups. And this is based on the ONS prevalence survey. And it was in this context that we developed our study questions. So our first question was, what was the prevalence of SARS-CoV-2 associated hospital admission amongst the population of children and adolescents, which numbers around 12 million, those younger than 18 years, resident in England. And we started our study era in the period after the community testing program had commenced. And we commenced our cohort study from the 1st of July 2020 until the most recent available data, as was at that time, which was the 31st of March 2022. And we asked the question, what types of hospital admissions occurred in this population of children? And in particular, we were interested in how many admissions were due to SARS-CoV-2 or where SARS-CoV-2 was contributing versus how many were with, which is often referred to as an incidental admission, where SARS-CoV-2 is a bystander in a child that's or adolescent that was admitted for another reason. We also asked what were the risk factors for hospital admission. Obviously, we were aware that there were risk factors of underlying health conditions. And we'd noted from some other studies and also from the clinical practice of those involved in the group that ethnic minority groups and possibly deprived children were disproportionately affected. And we also had questions from parent groups about the role of vaccination. And then we wanted to understand how many children and adolescents experience severe disease related to SARS-CoV-2, meaning those who required critical care during their admission and or those where the child was diagnosed with PIMS-TS. So these are scenarios that were identified by JCVI and SAGE as more severe disease, and as intensivists, several of us on the group, obviously we agreed that was a very good measure of severe disease. So our study team is listed here, the immediate study team, and this is an interdisciplinary research group where we have 7 people who have an analytical background. So by analytical, I mean data analysis type of skills. We have 3 people, which includes myself and Chris, who have clinical and also some analytical background. And then we had 5 people who are clinical experts in pediatrics and clinical research, all of whom had some interest in SARS-CoV-2 in children. We also involved patients and public in our research through various ways. So obviously, firstly, as we're part of the consortium, we presented our research plan to the Patient and Public Oversight Panel of the CVD COVID UK COVID Impact Consortium before we started, and they expressed strong support and interest and raised a few questions. We also were able to interview 2 families of children who'd been in hospital with SARS-CoV-2, where a colleague from Great Ormond Street, who's very skilled in interviewing, did talk with them about their experiences of their child becoming unwell and being admitted. And then clinicians on the research group reached out to colleagues and also provided other informal feedback about patient and parent experiences. And one of the things we were quite mindful there was that all the clinicians on the research group are from tertiary centres, and so we reached out to also colleagues from non-tertiary but acute care settings to get some opinions from them as well. And then we liaised with parent groups, mainly via email and social media, and then we had feedback from a couple of these groups about the proposal So this is the summary of our PPI.
So I'm going to now walk you through the methods side of our study. I'll do this focusing mainly on the admission types, as that's probably of most interest, and would strongly encourage you to read the paper for the details, because this was a complex process. So data sets wise, we used all available data in the trusted research environment, spanning COVID-19 testing, primary care, secondary care, death registrations, and COVID-19 vaccination status from the data sets shown there. As Kate said, we started our study on the 1st of July 2020, when the community testing programme had commenced, and we went up until the most recent available data at the time of analysis, factoring in 6 weeks of follow-up based on the kind of indicative time for PIMS to develop after COVID exposure. Our inclusion criteria were all those aged under 18 at the point of first infection, and an important difference from adults, that included both those alive at the start of the study as well as those born during the study. Some additional inclusion criteria around data quality control were patients resident in England with a valid pseudo-identifier enabling linkage and a known sex. We excluded all the reinfections that we could identify within the data, as well as subsequent admissions, so only focused on the first SARS-CoV-2 associated hospital admission. Now, in terms of identifying those associated admissions, we've previously done fairly extensive work on this within the consortium for adults. But to quote the kind of frequently used medical education mantra of paediatricians, children are not just small adults. And as Kate highlighted already, and as shown by these range of news headlines, COVID presented very differently in children. And we really wish to kind of capture that in our approach. So, as Kate previously mentioned, our approach was very much a clinical data science collaboration. We used a paediatrician panel who were able to integrate knowledge both from the literature and the experience of themselves and colleagues in order to generate phenotype code lists with which we could query the data to produce insights that were then fed back to the paediatricians in a iterative fashion until we reached our final list of code lists, which we've now shared on the HDR UK Phenotype Library and GitHub repo. Once we had identified the admissions, we then wished to categorize them to address those study questions that Kate mentioned earlier. And we did this using a hierarchical approach to best approximate admissions due to COVID versus those with COVID, as well as complications such as PIMS-TS. I will preface this again with saying this is a complicated process that took us about 6 months to decide on, so please do read the paper for full details. We started off in our hierarchy by identifying nosocomial admissions or hospital-acquired COVID, based on the Public Health England definition, where the first evidence of COVID is on or after day 8 of hospital admission. We then identify incidental admissions by expanding on the code lists from the ISRIC study group in order to identify admissions that were primarily for reasons such as mental health, trauma, surgery, etc., i.e. not COVID related. Then we move on to identify those admissions due to PIMS-TS. And our approach to this included the use of code lists from the literature. And you'll note that some of the codes here are for rather rare syndromes like Kawasaki's, as well as broad syndromes like SIRS or systemic inflammatory response syndrome. And this really reflects the uncertainty around the emergence of PIMS TS and the resulting coding issues with that, where we know initially some of these existing codes were used to code PIMS TS. We did our best to mitigate the more non-specific nature of these codes by adding additional exclusion codes for other common causes of sepsis or SIRS, such as other specified bacterial or viral infections. Next, we move on to identify those admissions due to COVID. And again, we use two approaches to separate out the, if you like, the levels of evidence. Our first, type A1, was using diagnostic codes, as shown here. And then the second, type A2, using a, if you like, a more clinical definition, using codes consistent with pediatric COVID-19 presentations from both the literature and the clinical experience of the pediatrician panel. Finally, we sought to add some additional definitions, including those with those presentations with a condition that was known to co-occur with COVID-19, for example, viral or bacterial co-infection, severe complications such as type 1 diabetes or seizures, as well as procedures such as respiratory isolation in a side room, for example. And finally, we identify those admissions for conditions known to be high risk when coinciding with COVID-19. For example, immunosuppression, cancer, neurodevelopmental conditions, etc. I'll just touch on the identification of comorbidities a little bit more, because again, this is a key part of this study and a complex approach. This was partly anchored around identifying those conditions that were deemed high risk for severe COVID-19 and thus used to determine eligibility for vaccination, as kind of recorded in the UK HSA's Green Book. Again, our process was similar for generating code lists, using a pediatrician panel to review sources of information. Firstly, to code the Green Book conditions in order to determine vaccine eligibility and harmonise definitions with UKHSA. But secondly, by reviewing the literature and clinical experiences to develop a second broader set of conditions that encompassed additional factors known to be at risk of severe COVID-19, such as obesity and pregnancy. So I'll now hand back over to Kate to talk you through the results.
Thanks, Chris. So this is the figure 1 of our results from the paper, and the headline numbers were that amongst the population of around 12 million children and adolescents resident in England or born during the study, there were a total of 3.2 million first ascertained SARS-CoV-2 infections in the study period. And then of these infections that occurred, identified based on the combination of COVID codes plus the positive testing data, and then refined, as Chris has described, 29,230 involved a hospital admission. So in the figure across the top, we have the dates showing the span of the study. And then we have the variant era periods. So starting with the original variant, moving to the alpha period, the delta, and then the very end of our study captures the beginning, the first Omicron wave. And in the top panel, we present for context the prevalence of SARS-CoV-2 in the 2 children's age groups, which correspond to primary school age children. That's the top panel, which shows the peaks as reported by the ONS prevalence survey. Then in the second panel beneath that, we present the number of ascertained infections, first ascertained infections that we identified in the data from the consortium. And then in the third panel, we then present the number of infections. And in these panels, the total number is depicted in black, or sort of dark grey to black. And that includes the youngest group, who are those under the age of 2 who are not captured in the ONS survey. And you can see that the peaks of the ascertained infections tracks quite closely to what was found in the ONS survey, which is reassuring. And then we see the hospital admissions with a jump in hospital admissions during the Alpha, and then a kind of slow burn of them during Delta, and then the big jump that occurs in the Omicron, and that's depicted in that middle panel. And then if we go to the bottom 5th panel, we see the intensive care admissions. And these are similar to the hospital, but the level of jump in the Omicron era is a bit less for intensive care admissions. Then along the bottom of the figure, I just want to draw your attention to the flags which depict and report important events that were going on at that time that relate to children and SARS-CoV-2. And in particular, when interpreting the 4th panel there, which is the case hospitalization ratio, we need to think about the testing. So free testing was available prior to the start of our study, but obviously was recommended for children and indeed anyone who had a particular set of symptoms. And that may not have ascertained, obviously, all of the infections in children at the early period. And that could then be one of the reasons why the case hospitalization ratio appears quite high at the beginning. And then we have a period after the summer of 2021 and autumn of 2021 where there was reopening of society. And during that time, there was a lot of routine testing in schools, in particular, routine use of lateral flow tests, which will have helped to pick up lesser severe infections, so asymptomatic or very mild infections in school-age children. And therefore, that plot of the case hospitalization rate needs to be interpreted with the testing policies in mind. So this is a panel now reporting the first hospitalizations, so hospitalization associated with a first infection. And as has been said, there were just over 29,000 of these. And when the headline of this plot, which I'll go through in a little more detail, was that 21,000, meaning 71.8% of them, we found were either caused by SARS-CoV-2, so they were a COVID type presentation, or they were suspected as being COVID presentation, or there was a contribution, so there was COVID with other factors in the child's hospital admission. And we found that 26.9% or 7,855 were incidental. And we found a very small number of nosocomial, so it was actually less than 1% of all the pediatric hospitalizations that we picked up were nosocomial. The median length of stay was short, much shorter than you might find in adults, was only 2 days. Now, if you look at the bottom plot, this is mirroring what was shown on the prior figure, which is the number of admissions with the peak in the Alpha period and then a slow burn up in the Delta period with then that big peak again in Omicron. And if we then look at the top colour panel, the hospital admissions are broken down by type. So the incidental admissions, the red along the top, are reasonably constant, and we didn't appear to find that these change particularly with Omicron in terms of proportion, which is a difference to adults. The type A, the COVID type, are in the bright blue colour, and then PIMS-TS in green is more common at the beginning and then becomes, and we'll come back to that, a bit less common over time. And then the type B, which are contribution of SARS-CoV-2 to the admission, is a kind of minority. It's around 15% of admissions, and that's fairly steady over time. The next panel shows the breakdown of admissions by age group. What's quite notable is that the youngest children, which is the red in under 1, and then the kind of khaki colour, the 1 to 4-year-olds, they seem to account for quite a large proportion, particularly the under 1s. And then in the bottom, we have some information about testing status. So of the entire study cohort, around 17% were included based only on diagnostic codes, and they did not have a positive test in the window that would imply it was a positive test during hospitalization. And those were, for example, PIMS-TS, which is well known to frequently not have a positive test. Okay, next slide. So this is a similarly formatted slide, but this covers the subset of admissions who required critical care. So we have 1,710 out of 29,000, which is 5.9%, where the admission involved pediatric critical care. And then also, which is not depicted on this slide, but just as an important thing to report, is that we noted 70 deaths, and these have been rounded to 5 because of small numbers, 70 deaths which occurred with COVID-19, the vast majority, and a very small number with PIMS-TS as a cause of death. And amongst those, the majority of them were amongst the hospitalized, but there were actually a small number of deaths who were not amongst the hospitalized population. So if we then go to the panel, you see at the bottom in the grey colour, this is the intensive care, number of intensive care admissions with a peak in the alpha, and then again, the peak in Omicron, which is not as big a jump as the hospital admissions. And then if you look at the hospital admission types amongst the ICU admissions, what we see is that there is less incidental. So there's only around 14% of these are incidental. And there is much more PIMS-TS. So the green color is PIMS-TS, and you'll see, because that's a more serious condition, those were more likely to feature in intensive care. And then we have actually not the majority, but a reasonable number were the COVID type, the bright blue, and then we have this sort of purpley color, which are the type B. So this is where COVID SARS-CoV-2 is a contributor with other factors. So complex children, maybe with multiple infections, one of which is COVID. Then going to the age groups, again, we see the younger children, the red and the khaki color, are very overrepresented. So for particularly the young babies again. And then the testing status, amongst the ITU, there were more children who didn't have a test positive in window, and that's largely accounted for by PIMS-TS, which is a post-COVID inflammatory syndrome. So now we're going to look at some of the risk variables, and I've put some sections from the main data table from our paper in the BMJ here. The headline on this slide is that amongst the SARS-CoV-2 associated hospital admissions, boys were more likely to be represented than girls. And as mentioned, the younger children, especially infants, they were also much more likely to be hospitalized. So across the top of this table, we have the total number of first SARS-CoV-2 infections, followed by the total number 3,197,000, which are the positive test only with no admission. And then we have the SARS-CoV-2, total SARS-CoV-2 associated hospital admissions. And then we have each of the admission types. Then if we look at the male proportion is higher for all the admission types which are linked to SARS-CoV-2 as a causal factor. And whereas for the other columns, the female proportion, the girls, is a higher proportion. So that's, I think, quite interesting, and the most pronounced was for PIMS-TS. The boys were more severely affected. And then just to draw your attention in the age groups to the infants, where positive test, they make up only 1% of the children who had a first infection ascertained only by a positive test, whereas they make up 28.7% of the hospitalized children. So infants very markedly overrepresented amongst the hospitalized versus the test positive only. So one factor they're less represented in the tested population. They're not at school having lateral flow tests, but it's likely that there's also greater vulnerabilities amongst that group. Here we have some data on ethnicity and deprivation. So this is again taken from table 1 in our paper. And the headline findings are that the white children and those in the least deprived group were the most likely to appear in the test positive ascertained first infection group. And they were least likely to appear in terms of their number in the population in the hospitalized group. So the white population, which is represented in the table, you can see that they made up for 81.4% of the test positive, as compared to 69% of the hospitalized, and the least deprived make up 22.8% versus 13.8% of the hospitalized. That's the least deprived. And in kind of stark contrast, Black or Black British children and Asian British children and the most deprived groups were most likely to be in the hospital admission group, and they were overrepresented in that group as compared to the test positive only group. So, for example, we see Asian British children account for 8.5% of the test positive, but 15% of the hospital admitted group. Then I was just going to take that one more step, Chris, if we go back. The Black or Black British and high deprivation children, furthermore, what we see is that amongst the test positive first ascertained infection in the Black population, there was 2.7%, whereas amongst the wider population, that we would expect more like somewhere in the 3%. And then children, 24% approximately of children live in addresses in the most deprived quintile. But in the test positive group, we have 19.3%. So this might suggest that those groups were actually potentially less likely to be tested, as well as more likely to be hospitalized. Sorry, we can now move forward. So coming to underlying health conditions, as we've said at the beginning, we knew before we started that children with underlying health conditions were more likely to be hospitalised. And we found that the children who matched to the list of conditions that are on the vaccine eligible list published by the Health Protection Agency, etc., accounted for 37.9% of hospitalised children, as shown in this table. And then when we considered a wider range of conditions, some of which had lower severity, so they're overlapping but wider range, and we also included obesity across all age groups, we found that 54.2% of hospitalised children had one of these conditions. And then, as you can see in this table, looking across, we have the critical care subset, and then we have the children who sadly died. The proportions affected by all of these types of underlying health conditions increases with the severity of the COVID-19 or the SARS-CoV-2 associated disease, with the highest proportion amongst those children who sadly died. Here we have a graphic which explores the proportions of children who received vaccination. And we've only considered in this graphic children who are aged over 12 years who had a first infection after July the 19th, 2021. We present some notable authorization dates for vaccination in children in figure 1. And we've only considered, obviously, in this, the ones who had eligibility during the period of our study. And what you can see here is represented by the purple was that obviously not being vaccinated was quite a prevalent state for children, and that there were more children who gradually received vaccine over time. So the 1 dose is the green, and then really quite a small number who received 2 doses. And that what we found was that amongst the children who did have an underlying risk factor, which is the bottom panel, they were more likely to receive vaccination, but still a reasonable number had not received vaccination when we analysed the data. We also found that amongst first infections who did not require hospitalisation, the overall proportion of unvaccinated was 69.4%. Amongst those who were admitted to hospital, unvaccinated proportion was somewhat higher at 74.7%. And there was a very high proportion of unvaccinated state amongst the children admitted to critical care. So the majority, 88.9%, were entirely unvaccinated. And the figures might support a hypothesis that vaccination is beneficial against severe disease, although obviously our study is not designed for that purpose. And then finally, I've got a panel on the proportion of adolescents and children hospitalised with first infection, sometimes referred to as case hospitalisation rate. And as I mentioned with the figure 1, we have to kind of treat these numbers with some caution because of the changes in testing policies over the duration of the study. So the rates of first ascertained SARS-CoV-2 associated hospital admission appear, based on this, to have been higher in the original and alpha variant periods. However, we think it's highly likely that the lateral flow testing freely available in the Delta and Omicron eras was a factor in kind of producing these somewhat lower numbers of 0.7 and 0.9% for those. We also note that the absolute number of children hospitalised was considerably higher in Delta and Omicron, the short part of Omicron that we captured. So it was 2000, 445 and 3300 for the 2 earlier waves, and then jumps up for those 2 later waves. On a positive note, we found that the rate of the critical care admissions and PIMS-TS admissions fell over time, and appears the PIMS-TS, which is shown in the purple, appears to have dropped quite notably over time and become less prevalent. And that may be because as children have been exposed, they're becoming less likely to get PIMS-TS. And indeed, this has now been reported from a few different international groups. So what does our study add? We found that 71.8%, or the majority of admissions, were either due to SARS-CoV-2 or SARS-CoV-2 was a contributor. Concerningly, we found that ethnic minorities and more deprived children were very disproportionately represented amongst hospital admissions. And they were also disproportionately, which is not reported in the talk I've just given, but you'll find this in the full paper, they were disproportionately represented amongst critical care, and also amongst there were PIMS-TS children who did not require critical care, but that's also a more severe presentation. Infants were the most likely group to be admitted to hospital, and that we found that severe disease appears to have decreased, and that certainly falling cases of PIMS-TS contributed to that. Severe meaning critical care. So limitations, the SARS-CoV-2 testing policies varied considerably over time. Ascertainment of mild or asymptomatic cases will have also varied, becoming more likely in the later periods, and this will have affected our findings. We note that although we aim to identify children with conditions linked to greater vulnerability, i.e. the ones eligible for vaccination, we believe very strongly that our methods will have led to over-ascertainment. So we will have ascertained all types of asthma rather than only severe cases, for example, which is the intent of the guidelines. So we will have overestimated the numbers of those children. We acknowledge that case ascertainment based on codes, which we did use codes for our case ascertainment, it is dependent on availability of the correct codes and up-to-date coding practices. And that does come up in the ascertainment of PIMS-TS. We did a sensitivity analysis around PIMS-TS where we looked at the ambiguous codes and how they were being used in prior years, and we've presented some detail about that in our paper in the limitations section. And we believe that the vast majority of the cases we ascertained were correct, but obviously we can't know whether they're all correct. Our study focuses on acute illness only, and this is something that the patient groups brought up with us, that they wanted to remind us that when you recover and you're discharged from hospital, that doesn't always mean you're fully better. So it's limited to the acute period of hospitalization. So in conclusion, concerns that should be considered in public health initiatives that definitely in children appear to have been differential impacts on ethnic minorities and more deprived children. The rate of hospital admission in infants under a year, which requires probably a further look. We think it will be helpful, and indeed we're engaged in that at the moment in looking at later trends in some of these to see whether the drop in very severe children has been maintained and continued, which we all hope is the case, but has the continued number of infant admissions, has that continued, and if yes, what would be the implications of that? We know that infants are more susceptible to all types of respiratory infections. For example, RSV affects more infants every year than even what we've reported for COVID, SARS-CoV-2. but the infant group is a special group that needs further thought, possibly. And then in final words, we would like to thank HDR UK, the BHF Data Science Centre and all the team. And we would especially like to thank parents and parent-patient groups who helped and advised us, and the wider study team and their contacts who are acknowledged in the full paper. Thank you.
Many thanks, Kate and Chris, for your fabulous talk today. The link to the paper has been posted in the chat, but if anyone has missed that, feel free to reach out to us and we can share the link to the paper with you. We've unfortunately run out of time for questions today, but we thought it was important to let Kate and Chris complete their presentation in full so that we have a recording of it in case you want to watch it again, or for anybody who missed it. But thanks to all of you for attending, to Kate and Chris for presenting, and any questions that have been raised, we'll seek answers to them and send them to the people who've raised them. Just to let you know, our next webinar is on the 20th of September, and registration details will follow in due course. But thank you everyone, to Kate, Chris, and everyone who's attended once again, and enjoy your summer.
Thanks all. Cheerio.